Let us see this case, students. A 60-year-old male with history of alcohol abuse is evaluated because of insidious onset of dyspnea over course of 6 weeks. He is having a moderate right pleural effusion, serum amylase 20 units per liter, glucose, pleural fluid values are given. His protein ratio is 0.2, LDH ratio is 0.3. Other lab results show serum albumin of 2 gram per deciliter, prolonged prothrombin time, normal urine analysis. ECG is also normal. Which of the following is most likely diagnosis? Whenever they give you any question on pleural fluid analysis, first know whether it is transudate or exudate. By the data, the protein ratio is 0.2, LDH ratio is 0.35. This is a transudative effusion. Whenever there is a transudative effusion, think about heart cause, liver cause, kidney cause. Can it be a heart cause? ECG normal and history is also not suggestive of a cardiac disease. Can it be pancreatitis, lung cancer? No, because they are exudative pleural effusions. Can it be hepatic hydrothorax? Yes, because patient is having alcohol abuse. And your liver is the source of protein. Because liver is not functioning properly, protein is less, and liver is necessary for proper functioning of the clotting mechanism. Because your liver is not functioning properly, the clotting mechanism is also not good. So that's why the answer here will be hepatic hydrothorax. Hepatic hydrothorax means pleural effusion due to liver disease. What is this disease? There is rupture of alveoli, air escaping into pleural space. This is called as pneumothorax. Already we have discussed the clinical signs in pneumothorax. It is a pushing lesion. If you percuss, there will be hyperresonant or tympanic node. On the chest X-ray, what do you notice? Hypertranslucent area with compressed lung margin. Let us see the classification of pneumothorax. Pneumothorax is broadly classified into spontaneous pneumothorax, traumatic pneumothorax. Spontaneous pneumothorax, traumatic pneumothorax. Again, in the spontaneous pneumothorax, we have primary spontaneous, secondary spontaneous. Primary spontaneous, secondary spontaneous. In the traumatic pneumothorax, there is trauma happening in the hospitals called as iatrogenic pneumothorax. Trauma happening outside, direct chest injuries. When will this happen? Generally during road accidents. This is usually dealt by surgeons. Now let us see the medical causes. Primary spontaneous, secondary spontaneous and iatrogenic. Primary spontaneous. There will be no pre-existing lung disease. Patient will not be having any pre-existing lung disease, but still he develops pneumothorax. There will be no pre-existing lung disease, but still there is pneumothorax. Exact mechanism is not known. Coming to secondary spontaneous pneumothorax, there will be a pre-existing lung disease. There will be a pre-existing lung disease resulting in pneumothorax. Then what is the most common lung disease responsible for pneumothorax? What is the lung disease? In which lung disease there are hyperinflated areas called as bullas, which can rupture resulting in pneumothorax? It is COPD, emphysema. Apart from that, tuberculosis. In TB, the cavities can rupture resulting in pneumothorax. ILDs. Why it happens in ILDs? When I discuss ILD, I will let you know in detail. And rare diseases such as Langerhans histiocytosis, lymphangio, leiomyomatosis. Just write down LCH, LAM. I will discuss in the next slide, don't worry. Coming to iatrogenic causes. What are the hospital causes of pneumothorax? I told you previously. I asked my postgraduate to get some sample from the pleural cavity. He inserted needle very deep, damaging the lung. Air from the lung escaped into the pleural space. What is this common procedure called as thoracentesis? During thoracentesis, there can be pneumothorax. Next important reason is invasive mechanical ventilation. Invasive mechanical ventilation. Why will invasive mechanical ventilation be a reason for pneumothorax? This is a positive pressure ventilation. When you give excess positive pressure to your alveoli can rupture. Air from the alveoli, whenever alveoli ruptures, air can escape into the pleural space, resulting in pneumothorax. Then insertion of central venous catheter, especially subclavian catheter. Insertion of central venous catheter, especially subclavian catheter. Whenever your peripheral veins are not accessible, you go for central venous cannulation. So one is jugular, other is subclavian. So if you want to puncture the subclavian, you have to puncture beneath the clavicle. Whenever you are puncturing beneath the clavicle, accidentally lung apex can be damaged. Whenever lung apex is damaged, what will happen? Air can escape into the pleural space. The classification of pneumothorax, we have spontaneous, traumatic. Again in traumatic, iatrogenic, direct chest injury. Primary spontaneous, secondary spontaneous. And what is the most common lung disease responsible for pneumothorax? Your answer should be COPD. Now I have written that diseases like LCH and LAM can cause pneumothorax, even though they are very rare in clinical practice, but they have a specific clinical scenario which can attract the examiners to frame a question. So write down rare lung diseases causing pneumothorax. On one side, we will discuss Langerhans histiocytosis. On other side, lymphangioliomyomatosis. Let us see the mechanisms, clinical presentation, CT chest. Langerhans histiocytosis. The mechanism is there is abnormal accumulation. There will be abnormal accumulation of Langerhans cells. Abnormal accumulation of Langerhans cells in various parts of the body. It can get accumulated in the lung. It can get accumulated in the bone. It can get accumulated in the skin. Because of accumulation in the lung, there will be damage to airways. Airway involvement. There is airway involvement that can result in a cyst formation. Airway involvement that can result in abnormal area of air called as cyst. In the bone, one can notice osteolytic lesions. In the skin, there can be rash, there can be vesicles. In the skin, there can be rash, there can be vesicles. Clinical presentation generally seen in young males. Young males, smokers. These people are smokers and they present with pneumothorax. These abnormal areas of air in the lung can rupture. Kindly know this, students, whenever there is an abnormal area containing air, it is unstable, it can rupture at any point of time. CT chest will show bilateral upper lobe predominant, bilateral upper lobe predominant disease. And what do you see? You can see cyst. Along with cyst, some solid areas called as nodules. Some solid opacities called as nodules. Then treatment is generally smoking cessation, which nobody will do. Smoking cessation. Along with that, These Langerhans cells are also some abnormal immune cells. To bring down the immune response, you may need to give steroid, smoking cessation along with that steroid. Coming to lymphangioliomyomatosis. This is abnormal proliferation of smooth muscle, atypical smooth muscle. Abnormal proliferation of atypical smooth muscle along lymphatics of, as the name indicates, lymphangioliomyomatosis. There is abnormal proliferation of smooth muscle along the lymphatics of lung, and also along the lymphatics in the abdomen. So coming to the lung. So within the lung, what will happen is there can be damage to the airway because of this abnormal proliferation, airway involvement, and this airway involvement can result in cyst formation. And also sometimes the pleural lymphatics can be involved. So there will be pleural lymphatic rupture. Because of excess proliferation, it can rupture. Once the pleural lymphatics are ruptured, what is going to happen? What does lymphatics contain? Lymph. What is lymph? It is nothing but a type of chyle. So there will be accumulation of chyle resulting in chylothorax. In lymphangioliomyomatosis, there can be chylothorax. The reason is the pleural lymphatics can rupture resulting in accumulation of chyle. So so lymph is nothing but chyle. So pleural lymphatics rupture resulting in chyle. In the abdomen, especially in the kidney, you can see a growth. That growth is called as angiomyolipoma. So in the abdomen, over the kidney, there can be a growth. That growth is called as angiomyolipoma. Now why there is such abnormal proliferation of smooth muscle? They thought it is due to mTOR, activation of mTOR protein. Abnormal activation, mTOR protein activation. They thought this was due to abnormal protein called as mTOR activation. So why this was happening? Because of mTOR protein activation. Then clinical presentation. Here these patients will generally be women of young females, reproductive age, and because of this cyst, it ruptures resulting in pneumothorax. Women of reproductive age presenting with pneumothorax. And the CT chest, it will be bilateral diffuse, top to bottom, side to side, all areas. You can see multiple cysts. Coming to the treatment, here the treatment is, why it is happening? Because of mTOR protein activation. We give mTOR inhibitors. What is that mTOR inhibitor? It is called as sirolimus. And ultimately, this Langerhans cell histiocytosis, lymphangioliomyomatosis, if they are progressing, they might require a lung transplant. Ultimate treatment will be a lung transplant for both. We can give mTOR inhibitors such as sirolimus, but when they progress, ultimate option available is a lung transplant. This is regarding the differences between LCH, Langerhans cell histiocytosis, LAM, lymphangioliomyomatosis. Let us see how to differentiate cavity, pneumatocoel and cyst, because all these are air-filled areas. Once you see in a CT chest, you will be confused how to differentiate. Now these are three air-filled areas. I want you to identify which is cyst, which is cavity, which is pneumatocyst. Now, if you see the first image, it is called as a cyst. Cyst is generally a rounded area of air with well defined wall. You can see a rounded area of air, and most importantly around it you can identify a wall, but its dimension is less than 2 mm. There is a clear wall, the dimension is less than 2 mm and it is interfaced by normal lung. Coming to cavity, cavity is also air filled area, but the dimension of the wall is generally more. Air filled area with well defined wall, usually more than 1 to 2 mm in dimension, and it is associated with consolidation or mass. Cavity will not happen solitarily. It will be associated with some other pathology. You can see here there is consolidation here, with some other pathology such as consolidation or mass. See the difference, students. This is a cyst. I will zoom it so that you will not forget. So, this is a cyst. It is an air filled area. This is a cyst. You can see the wall clearly, but as cavity it is not so significant. See, there is a wall, you can perceive it completely. In the cavity, the wall is having dimensions more, and also it can be associated with some consolidation or mass. Then coming to pneumatocyst, the third image is pneumatocyst. This is an air filled area. There is no proper wall at all. There is air filled area. See, there is a wall up to here. In this area there is no wall at all. There is no proper wall at all. It is an irregular air filled area and usually associated with acute pneumonia. See the difference. In this cyst you can notice well defined wall. Here there is no proper wall at all. Here there is well defined wall. The dimensions are generally more, associated with surrounding consolidation or mass. This is cavity. All these are cysts, and this will be a pneumatocyst. Let us see the first image. This is Langerhans histiocytosis with upper lobe predominance. Can you see the cysts here? So, they are scattered here and there. In the upper lobe. So, mostly you are going to see them in upper lobes. Whereas the next image, if you see, they are diffuse, bilateral, top to bottom, side to side. You can see there are cysts in all the quadrants. Diffusely distributed. This is lymphangioleiomyomatosis. This is the difference. See the CT here, students, between this and this. Here cysts are not throughout the lung. Here and there you can see cysts, and there are so many empty areas, but here there is diffuse involvement, top to bottom, side to side, everywhere it is involved. So, this involvement is LCH, and this will be LAM. LCH usually in males, LAM generally in females. Coming to important type of pneumothorax for your exam, called as tension pneumothorax. For tension pneumothorax to happen, first prerequisite is there will be presence of large air leak. And this air leak functions as a ball valve or one-way valve. This air leak functions as a ball valve or one-way valve. What is this? Now consider this is the healthy lung, and let this be the pleural covering, and on this side the diseased lung. There was an air leak. Because of the disease, there is a large air leak. Air is leaking into the pleural space. Because of that, there is a pneumothorax. And they have come to know that this air leak was functioning as a one-way valve. Exact reason is not known. What is meant by one-way valve? During inspiration, air will go into the pleural space. During expiration, nothing is coming out. During expiration, nothing is coming out. Because of that, with each inspiration, there will be increased positive intrapleural pressure. Once the intrapleural pressure increases, there will be compression. There will be compression of adjacent lung. There will be compression of adjacent lung and mediastinal vessels, students. Compression of adjacent lung and mediastinal vessels. Now, whenever the mediastinal vessels are getting compressed, there will be great vessels in the mediastinum. Because they are getting compressed, venous return will not reach your lung. There will be decreased venous return. There will be decreased venous return. Because of reduction of venous return, there can be decreased cardiac output. There can be decreased cardiac output that will result in hypotension. That will result in hypotension, ultimately shock. Now, why this is called as tension pneumothorax? Not because patient is in hypotension and doctor is in tension actually. Why all this phenomena is happening? Because of increased buildup of pressure within the pleural cavity. Because of increased buildup of pressure within the pleural cavity. What is the other name of pressure? Pressure is also called as tension. So, this is happening because of buildup of tension in the pleural cavity. So, it is called as tension pneumothorax. Because this is presenting with hypotension shock, always tension pneumothorax is a medical emergency. It is a medical emergency and a clinical diagnosis. No need any investigation to prove it is tension pneumothorax. If you feel it is tension pneumothorax, you should intervene immediately. What are the important clinical diagnostic features? These patients will have absent breath sounds. Absent breath sounds. They present with acute shortness of breath. There will be hyper-resonant note on percussion, and they will have hypotension. They will have hypotension. If you find this combination, your diagnosis should be tension pneumothorax. And what will be the next step or best step? Next step or best step is always an intervention to save the life of the patient. What is that intervention? You should insert wide bore needle followed by intercostal drain on affected side. Now, there is lot of pressure within the pleural cavity compressing your vessels. There is no proper circulation. By putting a needle, you can relieve the pressure. The compression will be relieved, the circulation will improve, and patient life will be saved. Now, you can get a doubt, why not go for intercostal drain in the first instance itself? Students, intercostal drain insertion is a minor surgical procedure. It will take few minutes. In that few minutes, patient may not survive, whereas putting a needle, it will only take few seconds. So, insertion of wide bore needle will save time, will save the patient's life, and later you can go for ICD when everything is arranged. So, wide bore needle is put initially to save the life immediately. So, that single needle cannot drain the whole air For better drainage, we go for ICD insertion. So for better drainage, you put a tube. Why not ICD as the first step? Because ICD is a minor surgical procedure. It will take some time. It will take few minutes for the procedure. In that few minutes, patient may not survive. So emergency is always wide bore needle. Emergency is always wide bore needle. Now the next question will be, what will be the ideal site of needle insertion? What will be the site of ICD insertion? For ICD, it is always a single answer. Fifth intercostal space near the mid axillary line. Fifth intercostal space near the mid axillary line. For needle insertion, according to new guidelines, it is also fifth intercostal space mid axillary line. If it is not given in the option, you can go for old guidelines, second intercostal space mid clavicular line. To avoid confusion, now they have made it uniform. For needle and for ICD, it is the fifth intercostal space mid axillary plane. If for needle, if fifth intercostal space is not given in the option, you can also go with the old guidelines, second intercostal space mid clavicular line. Let us see some cases so that you can understand pneumothorax better. Case number 16. A 64-year-old male requires endotracheal intubation and mechanical ventilation for COPD. This is a dangerous combination. There is IMV, invasive mechanical ventilation, the two in COPD. You were called because there is a hypotension. He developed hypotension. Absent breath sounds. Breath sounds are absent on right side and clear on the left. What is the best course of action? What can be the diagnosis? Possibility of tension pneumothorax. This is a dangerous combination. Ventilation, invasive mechanical ventilation and COPD. So the diagnosis is a tension pneumothorax. In tension pneumothorax, don't even think about any other option. The single option should be saving the life of the patient. Place a wide bore needle in the right anterior second intercostal space to alleviate a tension pneumothorax. The next case. Male with car accident, dyspnea, chest pain, anterior chest wall bruit, peripheral pulses are present. In percussion, there is tympanic note. Pelvis was normal. Decreased breath sounds on left side. Tachypnea with BP low. So trauma history. There is trauma history. There is tympanic note. Hyperresonant or tympanic note. There is decreased breath sounds. All this suggests there is an ongoing pneumothorax. The best answer is pneumothorax, students. Option A. The best answer is pneumothorax. Few students might mark it as hemothorax. Why hemothorax is not the answer? In trauma, hemothorax can also happen, but it is blood. Blood is a fluid. It will not give tympanic note. Blood generally gives stony dull note. Now why not collapse? Collapse will also not give tympanic note. Why not cardiac tamponade? Cardiac tamponade has nothing to do with tympanic note. So the answer here will be a pneumothorax.